Okay, I think we're ready to get underway. Good evening, everybody. Welcome to the last Health and Adult Social Services Scrutiny panel of the municipal year. My name is, for those of you who don't know me, I'd like to welcome you to tonight's meeting. I'm having some connectivity issues, so forgive me if I suddenly disappear. We have a quite busy agenda, so we'll try and make some progress. I'm not aware of any apologies for absence this evening, aside from Councillor Murtagh, who may be a little bit late getting in. Has anybody got any apologies for absence that they're aware of? No? Lovely. There are no urgent matters. I do need to ask members of the panel if they have any declarations of interest. And I'm looking at Councillor Burke, because yes, Councillor Burke.
Yeah, I'm a non-exec director at Hillingdon Hospital, and also for tonight, probably to note that we share a chair with Ealing Hospital, so our chairperson is the same.
Thank you, Councillor Burke. And Chris Hilton has just informed me that we need to recognise apologies from Sarah Rushton from the West London Trust. Chris is joining the meeting on her behalf, but he's always welcome, of course. He's been a regular at these meetings for a while. I don't see any other declarations of interest, and I don't have any matters to be considered in private, as far as I'm aware. So we have minutes of the last meeting, and there are a couple of things we need to tidy up before I ask you to accept these minutes. Unbelievably, we didn't have Councillor Steed down as present, so we need to rectify that. And we also need to make sure that we're identifying the Ealing Sabre NHS organisation correctly. So those two corrections to the minutes are noted and will be added in. Are there any other comments regarding the minutes from the last meeting? I think we've got Councillor Murtagh now, so lovely. I don't see that there are any indications, and I should say you can indicate in the chat box, or you can just wave at me. Okay, I'd like to ask if we can accept those minutes as a true and correct record of the meeting, please.
Agreed, Chair.
Thank you, Councillor Cordier, I appreciate that. Lovely. Right, we shall move on then to the first item of business, which is an overview on developments with Ealing Hospital. We're joined by Simon Crawford, the Deputy CEO and Director of Strategy, and Joanna Paul, Operations. Who is going to go first? Is it going to be you, Simon?
It will be me, yes, and Joe will drive the slides for me, I hope. So hopefully that's going to work between the two of us. So first of all, thank you very much for the invitation to come and report to Scrutiny this evening. And you know, obviously the last year has been a fairly momentous year for us nationally, but certainly in terms of the health service in terms of responding to COVID. And I think in terms of today, what I'm looking to do is really respond more specifically in terms of or talk about how we responded to wave 2 of COVID over the winter months. And first, I think I have to say a massive thank you to our staff who absolutely have risen to the challenge in terms of responding to COVID. Both the first wave, then focusing on recovery over the summer months, and then as we hit winter, going back into facing the COVID-2 wave. They've done an absolute sterling job in terms of responding to that. And hopefully some of you will have seen the good publicity I think we got in sort of December, sort of January period, and the filming that took place at Ealing Hospital as well as at Northwick Park, illustrating how we had responded within the trust to COVID. And also a massive thank you to our partners who have supported us as well. So both the local authority, the CCG, and indeed the voluntary sector, and indeed the public as well, so supporting the efforts of the NHS and Ealing in particular locally with contributions of food and other support throughout the period. But specifically then in terms of the hospital, Joe, can we go to the next slide? There's a couple of the presentation split into sorry, go back one. To the 4 elements. First, I'm going to talk about how have we managed in response to COVID, and there's a few slides I'll go through. I'll talk about some of the how we had to respond in terms of some of the interim service changes we put in place that meant we stopped doing certain things at Ealing Hospital and where we are with some of those restarts. Talk about some of the investment that we also have made at Ealing Hospital over the last 12 months, and then the more broader sort of collaborative working arrangements we've had in place across the ICS. So firstly, in terms of managing a response to COVID, we had to significantly reconfigure our estates. One of the things we learned from wave 1 was the importance of separating patients who are potentially positive and those who we definitely know are not positive for COVID. So we created what we termed red and green pathways throughout the hospital, and we put in processes for identifying people in terms of potentially having COVID by insisting on temperature checks as people came in, and obviously swabbing hands, etc. as they came through. So we created dedicated pathways in ED, ITU, and indeed our bed capacity at Ealing Hospital. So we had potentially COVID positive wards and definitely non-COVID wards throughout the hospital. So that involved quite a massive response on behalf of our estates team in terms of reconfiguring the pathways, but also in terms of the nursing staff, in terms of managing those definitive pathways, and in terms of the doctors, in terms of identifying the patients for those pathways, and indeed our sort of our diagnostic departments in terms of identifying those swabs which were positive, not positive, and putting in processes to swab people very quickly and turn around those results. So rapid installation of we also put in rapid installation of a command and control process within the trust. We had a COVID dedicated gold team in terms of looking at the prevalence and incidence of COVID coming into the hospital each day, and taking a view as to whether we needed to create more COVID positive wards, etc., whether we needed to increase capacity in critical care, that sort of thing. So we had a dedicated team managing that. The main control centre was at Northwick Park, but we also had a local control dedicated team on the Ealing site as well. And as I've sort of said, we flipped a number of wards and redeployed staff from other services to support critical care in particular, but also in terms of managing pathways and the front end of the hospital as well. So 8 out of 10 wards were supporting up to 170 patients with COVID-19 at one stage as part of the wave 2 response. And this was particularly challenging for us because not only were we dealing with the intensity of the COVID presentations and the challenges that presented to our staff in terms of emotionally, but we also had a number of staff who were also shielding. And unfortunately, we did have staff who were affected by COVID directly themselves. But we did learn from the first wave. We increased our testing capacity on site so we could test patients quickly in determining their likely status in terms of COVID positive or not, and triaging those and managing them with the appropriate treatments. We also, during wave 1, we learned in terms of the drug regimes which were likely to be most successful, and we also learned in terms of using oxygen therapy in terms of supporting patients rather than mechanical ventilation as well. So we had an improved outcomes, I think, as part of the response to wave 2, and a number of organisations, because we're at the forefront of wave 1, learnt from the things that we put in place at in particular Northwick Park, because that was hit hardest first, and we learnt from that in the second wave. We clearly worked as part of the ICS broader system in West London in terms of managing demand on a daily basis. So whilst I talked about our gold command within the trust, that gold command linked into the North West London ICS gold command process at 8 o'clock every morning. And that assessed the number of patients in critical care, that assessed the number of patients who were coming in presenting as being COVID positive, and agreed how we could manage that most effectively across the system. So we did get support from LAS with diverts from Ealing Hospital, but equally Ealing Hospital provided support to other sites like Northwick and like Hillingdon in particular in terms of managing diverts of patients to equalise the sort of demand and the ability to care for patients safely across North West London. And in particular, the challenges that we had around managing ITU provision, both at Ealing and within the sector as a whole. So we did transfer a number of patients out of Ealing who would come into Ealing, be admitted into Ealing ITU, but at any one time, we'd increased the ITU capacity up at Ealing to 11, I think, and 12 on one occasion on the Ealing site, but we then got support in terms of managing transfers out. So we always went into the night with some capacity for any new presentations coming in through A&E. So we were able to care for the sickest patients needing admission on any one day. We learned a lot about increasing infection control measures, using PPE appropriately, the front door screening, ward lockdowns when there was a potential outbreak of COVID on individual wards, and clearly enforcing our social distancing policies within the trust, and also testing our staff on fit testing for the masks when they're doing aerosol generating processes. And we had a rigorous process of staff testing, and clearly look to vaccinate our staff at the earliest possibility in January. So we sustained our urgent and non-elective services throughout in terms of including use of advice and guidance and virtual clinics for urgent and emergency patients where we could. And one of the key things that we learned from wave one was the importance of health and well-being for our staff. So we had health and well-being rounds to wards, regular staff briefings, regular listening events, regular chief nurse check-ins and refreshments to wards. And one of the big things, I think, the pluses I think we've all learnt during COVID is the benefits of digital technology in this type of meeting. So we use these extensively in terms of MS Teams within the trust to communicate with our staff and have large events so that we could brief our staff on the latest issues that we were dealing with in terms of COVID and provide reassurance and support as appropriate, and also as a means of giving them the opportunity to escalate key issues from their perspective. And again, as one of the things we learned from the first wave was that we had challenges in terms of keeping track of patients' belongings when they came into hospital, and unfortunately some did get disposed of as part of concerns around infection control processes. So we did improve that as part of our response to wave two, and we also put in mechanisms, although relatives couldn't visit, putting in arrangements for them to be able to drop off packages as care. And given that patients couldn't visit, we also used extensive online support in terms of providing patients to use things like iPads and things to communicate with their patients on the ward. So that sort of represents the whole range of initiatives that we've put in place in terms of responding, and I'm happy to take any questions of those in a second. But I think it's also helpful to outline some of the interim service changes that inevitably we had to put in place in response to COVID. And a lot of this was about redeploying staff from things like outpatients to support the wards, to support critical care. Lots of the therapy staff supporting critical care in terms of turning patients and proning them who are ventilated. It's absolutely key that you continue to turn those patients as part of safe care. So we continued with face-to-face clinics for clinically urgent and suspected cancer patients, and other face-to-face clinics were cancelled. We continued with advice and guidance to our GP colleagues. We had a continuation of phone and video clinics. Outpatient elective endoscopy was suspended from 25th of January to 22nd of February at Ealing, but it was restarted on the 22nd of February. And our outpatient clinics restarted on the 21st of March, and obviously phone and video clinics continue, but we're increasingly moving towards the availability of face-to-face outpatient appointments where it's appropriate for that and where it's needed. In terms of critical and respiratory care, as I've already alluded to, expanded high dependency respiratory care, so that includes the critical care and the high dependency beds, up to 18 beds on the Ealing site, and that we've now returned to 6 high dependency respiratory beds and 10 ITU beds on the Ealing site. That's what we've still got in place. Elective surgery was suspended on the Ealing site, and that was about protecting patients, protecting pathways, but also the anaesthetists were required to support the critical care response. But the elective surgery restarted from the 12th of April on the Ealing site, and we expanded that up again on the 19th of April, and during May we'll be looking to expand that up further again. Some urgent surgery continues at CMH. Daily emergency list for our CPOD list was initially suspended. That's now running 8 AM to 6 PM daily at Ealing currently. And overnight surgery was managed on a treat and transfer basis, and that still continues at this point in time. And again, it's about having the right resources to be able to consider bringing that back in due course. And originally we had intended to do that review in April. Our focus at the moment is on recovery and continuing to support the elective recovery in the backlog of operations that we've got in place. The main focus is on surgery at the moment, so we will be reviewing that in the latter part of this first quarter. In terms of trauma, non-elective trauma cases diverted to Northwick Park and St Mary's. Semi-elective, as I've indicated, restarted on 16th of April, and the semi-elective lists were moved to CMH 3 per week, and that divert is still in place. And as alluded to, that's part of the review that will take place in the first quarter now. Continuing that theme, diabetes and endocrine clinics remained at Ealing, and that's still the place. Imaging was paused for non-essential imaging, but all imaging is now operational on the Ealing site. Staff and vaccination hub, this was established in partnership with West London NHS Foundation Trust and set up in the main outpatient department, but that finished on the 16th of April, and pop-up clinics are now in place. The haematology day unit, that was temporarily transferred to CMH to maximise infection control and safety measures for these patients. So that currently remains at CMH. But again, we are reviewing that during the first quarter, and we will look at what is needed to be put in place, because I think we have to improve that. The place where that was previously is not fit for purpose to bring that back in situ there in terms of increased expectations around infection control for those patients. So we need to find a new footprint on the site to achieve that, but we'll be doing that this first quarter as well. And then we had our cath lab on the Ealing site, where we've had to decommission that predominantly on the Ealing site in March as a result of safety issues given the age of the equipment. We had already ordered new equipment, or plan to order new equipment that is now in place, and that we expect to have operational, because that'll take some time to arrive and to be put in situ. We expect that to be operational in the probably late summer, early autumn. We're looking to get that in place, and at the moment patients are being treated at Northwood Park. Next slide, please, Joe. So recognizing that talked about some of the things that we've stopped at Ealing, albeit most of those things are back. I thought it was also helpful to highlight some of the recent investments that we've put in place at Ealing. So we've opened a new same-day emergency care unit with parking and access for acute care for frailty in adults, and that opened in August 2020. And then during September to October, we upgraded our mortuary viewing room. We separated theatres for emergency planned care for rigorous infection control. We created a dedicated elective ward of 20 beds on 3 South at Ealing, and we introduced the thermal scanners at the entrance for temperature screening, provided new monitoring critical care equipment for ITU, A&E and 6 South. So that was a significant investment. And then in November, we created dedicated paediatric outpatient and day case area, and we've created a dedicated maternity and ultrasound scanning facility for our outpatients. And then more recently, as I alluded to earlier, we expanded the ITU and HDU capacity, ITU from 8 to 12 beds over 3 to 4 months. And we've started fitting sliding doors to all the ward bays to improve infection control processes. And then in April, we've installed 3 MRI scanners to be run by Imperial from June 21. We've restarted refurbishment of ITU, HDU to be completed during July 21. And we've installed a covered walkway outside ED to support social distancing. In total, so in the last financial year, we invested 3.5 million at Ealing, and that does not include the purchase of those 3 MRI scanners, which is in addition to that. And then lastly, just to say something about the collaborative working, I've alluded to some of that already in terms of the gold command and processes that we had in place. But obviously North West London CCG formally established 1st of April 2020. We're working towards a North West London integrated care system established in April 2022. That's not just ourselves, that's the sector. But from a London North West perspective, we've engaged across the sector, including providers and borough partners in North West London, oversight of gold that I've mentioned with the daily calls, but equally the weekly gold calls still continue for acute trusts. Planned care recovery meetings are in place, and we're working with the sector in terms of mobilising that planned recovery of the elective and the backlog of outpatient appointments and diagnostics. We've got our urgent and emergency care delivery board, A&E delivery boards are up and running, and that's been massively supported by the work of partners in terms of discharges. We're engaged in the Ealing local borough ICP meetings, and there have been thematic leads assigned across North West London for discharges, vaccination hubs, clinical review groups, critical care, assisting planning across the sector on key issues. And again, we're working and engaged with the sector on both our planning for revenue and capital going into the new financial year. So the financial regime in response to COVID has been significantly different. It's not based on activity and units of income associated with activity. It's based on effectively a block contract based on spend. That's been agreed more or less, I think, for the first 6 months of this year, and it remains to be seen nationally what that will look like from September going onwards. But at this point in time, we're confident in our financial base for the first 6 months of the year, and we've got agreed capital planning process and allocation for this financial year as well. So I think that's a whistle-stop tour of the things I think I wanted to share and talk to you about, but happy to take any questions and respond to those. Unless, Joe, there's anything that I've missed or not quite got right that you want to add to.
No, I think that was pretty comprehensive. If there are further questions, obviously, any more details people want.
Yep.
Would you like me to unshare?
Okay, sorry, there's a slight delay on my. Yeah, if that's okay. But feel free to chip in as we'd like to add. I'm looking for indications from councillors and colleagues. I'm going to start with Councillor Burr. I've got you, Councillor Rise. I'll come to you in a minute, Councillor Burr.
Thank you. A couple of questions. One, so I'll ask them both, and then if you can come in. So the first one really is in terms of the cross-sector working, both with other hospitals and with the local authority. What are the big things that you'd like to maintain, and are we able to do that? I mean, for example, around the discharges, etc. And secondly, in terms of your internal working and of the ways you've been operating in outpatients, etc. Again, what are the things there that we might maintain that actually we might be able to still keep or might be better post-COVID?
Okay, so the big things to maintain in terms of the ICP in particular, in terms of Ealing, I think it is very much around the discharges. I think that's been a fantastic success. and not just for us in terms of London Northwest. I think across the whole sector, I think there's been a focus on discharges and discharge hubs, but we've significantly improved our length of stay performance and managed to keep flow through our A&E departments as a result of the support that we've had from sector partners in terms of discharge planning, both to step down facility, but both to patients' home and the support packages going into home, to residential accommodation and to nursing home accommodation as well. So that's been fantastic. I think one of the concerns is that a lot of the discharge hubs were supported and the discharge planning was supported by other staff being redeployed. And I think one of the challenges and risks for us is that some of that resource will disappear and will begin to silt up in terms of patients staying in hospital longer than is desirable. And I think there's a fantastic effort being made or recognizing that's an issue, and we need to make the case for continued investment and support in that. So I think that is one of the big ticket items. I think it's recognized, and there is a case for investment being made at this point in time. I think in terms of internally, then I think. So sticking with that discharge thing, so the discharge aspect in terms of out of hospital was really important. But I think the stuff we did internally in terms of improving our own internal processes to support that, in terms of making sure we have ward rounds taking place early in the day, making sure we have access to transport booked when patients need to go home, making sure we've got drugs prepared and all that kind of thing, and making sure that we haven't got delays in testing and all that. So that is also part of that continuum. But you're right, outpatients. Then I think whilst we recognise the need for returning to more opportunity for face-to-face, definitely I think some of the virtual clinics will continue to be maintained going forward, and we wouldn't expect to go back to the same volume of face-to-face as we had previously. And I think one of the new things that we need to focus on, and that as part of the ICP, is the emergence of the PCNs and the roles and responsibility of the PCNs, and also how as an acute trust we can support that around things like patient pathways for diabetes and frailty and end of life pathways and things. So I think there's more work for us to do in that space.
Thank you very much. And if Daniel doesn't mind, I just would also like to say thanks. I mean, the pressure that the trust has been under through the whole period, has been unbelievable. In fact, it's one of the worst in London, really, worst in the country. So, my personal thanks as well for that. Thank you.
Joe, sorry, did you want to come in?
I would just add with Simon, I think, so I was very involved with the gold support towards the latter end, and particularly January, February, when we were very challenged with critical care. And I think the support of the network, working as a system as it did, people were staying on till 10, 11 o'clock at night to make sure the site was safe, and that we sort of supported not just ourselves, but sector. So people wouldn't leave their positions until we'd got every hospital in the right place to go into the evening. So that work and the support of the transfer teams, which ran across the network, was really key, and people were picking up the phone and speaking. I mean, we had conversations with Hillingdon, with trusts across the sector to support that. So that sense of partnership. I suppose the other thing I would say is that I think Ealing felt very connected, and as a hospital, we felt very connected to the community. And felt very supported by our community as well. So I think, it was just amazing acts of people when we were bringing PPE to the site and bringing, all sorts of food and things. So I think we saw and felt very linked in as well. So that was something I'd love, I think it was really important.
Of course. Councillor Raza, I'll come to you, please.
Yeah, I'm having a few signal problems, so I hope you can hear me. I wanted to ask about getting the services down from that high alert to how they're working now, because I have been contacted by some residents who have said that they were very concerned about people in hospital now for various treatments not getting, shall we say, they should have. An example, who was taken into hospital with a bowel obstruction was actually put onto a COVID hot ward, despite being immunocompromised. So it's these little things that, well, quite big things really, but how are we managing the handling of people who have to go in for various other things, and what is the protocol to pop them on a particular ward or not, because she was COVID negative. I was absolutely incredulous that this had happened. So my concern is for people being moved around within the hospital now, in a sort of less heightened COVID alertness, if you like. And what's the process of being around the hospital?
Okay, it was breaking up a bit, so I didn't hear absolutely everything, but I think what I got the gist was a patient who was immunocompromised, got on a ward that they shouldn't necessarily have got onto, and clearly that shouldn't happen.
Yeah.
And obviously I can't comment on the individual case, but clearly we were trying to stop exactly that sort of thing happening, that patients would not go on a positive ward if they clearly shouldn't go, and if they go there and if they were negative. What I would say at the moment is Joel, correct me if I'm wrong, but I think there's about 3 COVID positive patients in Ealing at the moment. So we're in a completely different ball game at the moment. And I think at Northwick Park, I think there's 12. I think I saw on the SITS rep today. So in terms of COVID positive patients being in the hospital, that's a far less of a risk at the moment, but we are still testing patients when they're coming in, so that we are identifying those who are positive and cohorting them away from those who are not, and that process is in place. I'm sorry that it wasn't robust enough in terms of the case that you're talking about, but we have tried to maintain that throughout this second wave. In terms of access to diagnostics and people waiting, etc., then as I alluded to earlier, we have recommenced some of those things, but they have not. It's fair to say they're not all recommenced at the volumes pre-second wave, and they're certainly not all at the levels pre-COVID. But every week I chair what is called our recovery group on a Tuesday, and every week we're looking at how we can bring additional capacity back on stream without compromising our pathways. So at the moment we'll have a big step up. I think it's the 10th of May is our next step up in terms of our elective procedures in terms of operations. We are reviewing our endoscopy capacity at the moment, and we'll be testing that we've got as much open as we can at Ealing, and we've certainly got all our imaging, ordinary imaging up and available at Ealing. And as I've already alluded to, the outpatients, we're increasingly doing those face-to-face where that's needed. So hopefully the target for as part of the spring recovery for the NHS is to get to 75% of last September's activity by the beginning of June. And we're on track to do that. And then increasingly the targets get to 85% by September.
Okay, Joe, did you?
You're on mute, Joe.
I think you're still on mute, Joe.
Sorry, I thought I'd unmuted. I think a really important point you're raising about confidence of people coming in who need hospital and how we manage that. Initially, we didn't have tests for every patient. When we go back to when we started this, we had a very different level of testing. Now, every single patient that's admitted acutely and comes into the hospital is tested on admission, and then we retest them at day 3, day 5, day 7, and so we move forward. So that if there is anyone who's admitted who subsequently develops, we know very early. But the diagnosis of COVID testing is one form, and we know that there are testing is not the only answer. So it is a combination of somebody's history, their symptoms, what presentation, and X-ray and imaging and other mechanisms to assess where somebody's at. If people are coming in now and there is any question as to whether they have COVID or they have the potential of being exposed, then they are admitted into our infectious diseases ward, where they are held until they've had 2 negative tests. And that's how we work. But during the peak of the COVID pandemic, it wasn't always as straightforward as that. And there was a lot of, people came in and had been exposed and then developed COVID in wards, or equally came in with symptoms that they may have been negative, but actually there may have been symptoms there that the team were worried about, might have been symptomatic of. So I think it was a very, it's a complex piece and a complex picture that the teams are trying to unravel and work through. But we are very clear in the context of where we're at. Every patient has a test when they're admitted, and then they're admitted sequentially and don't come out of areas unless they're COVID negative into the main wards.
Okay, thank you, Joe. Councillor Raza, was there anything else? Because part of it was garbled. I just want to check that you got everything answered that you wanted.
Yeah, it was basically just to kind of see where we're at with the situation. Because there's a couple of cases that have come forward and contacted me about how they were a little bit concerned about how Ealing Hospital was moving their patients around, and I've had clarification on that. So obviously it's about getting people confident again, as Joe said, and that will take some doing, and it's a very complicated situation, so there's going to be 1 or 2 which get through an odd situation. So thank you, Bertie.
Put myself on mute there. Thank you, Councillor Raza. I'm going to go next to Mr. Alan Cook, who's waiting for us. Alan.
Thank you, Chair. There was a lot at the beginning in phase 1 talk about patients being discharged quickly from hospital into care homes. I don't want to talk about that. What I want to discuss actually is what was the situation about people in care homes who actually needed additional support being brought into hospital in phase 1, and in phase 2, when we had an even more numbers of patients, did you actually see a repeat of that happening, or had conditions in nursing homes improved so that that situation did not occur?
Ooh.
Do you want me to?
Yeah, do you want to go first, Joe?
Sure.
Hospital plan.
During phase 1, we absolutely accepted and had patients admitted from nursing homes who needed nursing care, needed hospital-based care. But I would say that actually during wave 1, we also had teams and worked with, Kate Senger, who is our frailty lead, was very much linked in with the GP lead for the Argyll care home, nursing homes, around support that we need to provide, as well as teams within the community also providing support into care homes. I think, the mistakes that were made during that first surge, I think, have been well rehearsed, sadly, in terms of the impact that it had in discharging, and we were working on the basis of advice and what we'd understood. But I think in wave 2, the lockdown of care homes was also really managed very tightly, and the outbreak. So we used to get a weekly update of care homes that could accept admissions, kind of a red, amber, green system, so that we were always aware of a status of a care home and whether we need to seek alternative placements. Chris has got his hand up, but community provided substantive support, allowing us to step patients down into bedded places, so that we didn't put them back into the care homes until they were negative. So I think there were differences, and there were a lot of lessons learned that we were able to take forward into wave 2.
So I'm going to see if Chris wants to come in since he's got his hand up, and then I'll come to you, Simon, in case you want to add anything, and then I might even come to Kerry Stevens as well. So Chris, would you like to go next?
Yeah, I just want to, I thought it might be helpful to the committee for me to add to Joe's comment and just advise that the care home service for nursing homes in Ealing comes under Ealing Community Partners. That's the service that's sometimes referred to as the Argyle contract, and absolutely we benefited greatly throughout the year from the input of geriatric colleagues from Ealing Hospital, and I know that Kate Senger, one of the local geriatricians, works very closely with Dr. Anna Down from the Argyle surgery. I agree with Joe that throughout, I know that Anna and her colleagues have been keen to ensure that patients who required escalation to an acute hospital were able to access that. And there was a lot of learning in terms of the discharge pathways, particularly later in the year. And of course, as you're aware, we had the Mary Robinson unit, and a similar facility now continues to exist as a transitional facility for people stepping down to protect the residents of care homes. So just to echo what Joe said, and to offer thanks for the input from
Okay. Simon, next. Would you like to...
The only thing I was going to add is that certainly as part of the wave 2, in terms of discharges to care homes, we're dependent on a negative swab, and insisting on the negative swab before that discharge took place to the care home. There are obviously different arrangements for those who were positive in terms of step downs, but they didn't go into care homes.
And Kerry, it's rather impromptu from me, but I didn't know if you wanted to add anything. Sorry.
Thank you, Chair. Just to echo the comments in terms of what Chris, Joan and Simon said, the importance of the response in the whole system.
I don't know if I'm the only one getting some dreadful feedback at the moment. Yeah, Kerry, we might have to have you write it in the chat box, and then I can read it out. We might proceed on that basis. So I'll wait and see if either Kerry can email it to me or put it in the chat box, and then I can furnish the committee with that contribution. But Alan, you may have I'm aware you may have other questions, or you might have another question based on what you've heard. So I'll just come back to you, Alan.
Thank you, Chair. So we've talked about it going in one direction from the hospital to the care homes, but the other thing that I'd like to know is what pressure that the care homes were putting on the hospital system of actually patients having to be admitted to hospital. In phase 1, was that higher or lower? And in phase 2, what was the situation then? And in fact, had the nursing homes learnt from phase 1 that actually they were managing the situation, they're not putting pressure on the hospital?
Yes, I think they had.
Yeah,
they had.
Yes.
Yeah, the admission rates were lower, but you know, the deaths were also lower because we'd learnt lessons and learnt how to manage it. Absolutely.
I'm just going to say that Kerry can contribute in the chat box or however he wants to this part of the question as well. But I'm going to read out what he's written for me and for the rest of you, and I'll come to Dr. Taylor in a minute. He's got his hand up as well. So Kerry has written, the importance of cross-system working has been key in terms of supporting discharges and also in terms of admissions. So that's the answer. Dr. Taylor, would you like to come in on this point? Sorry. Well, you're on mute, BJ, sorry.
Evening. I just wanted to add to your question, Alan, regarding nursing homes and the management of COVID within the nursing homes. I think, you know, in terms of COVID itself, there was a lot of learning, certainly in the first wave of COVID, in terms of how we manage COVID, generally speaking. And I think what we did discover is the way we can manage COVID, particularly with the use of steroids, dexamethasone, which had a significant impact in how we manage COVID. And so in the second wave, certainly the ECP, the team, the Argyll nursing home, was certainly managing high acuity patients in the nursing home in terms of their COVID symptoms, particularly the use of dexamethasone and the use of oxygen to try and manage and stabilize the patients, these patients, so they don't need to go into hospital. And certainly it was a steep learning curve, but I do believe that the staff at the Argyll nursing home, with support of ECP and nurses, obviously in the nursing home themselves, did an utmost to try and ensure that as many patients could potentially stay in the nursing home during wave 2 and have a positive and encouraging recovery from COVID with the higher acuity of intervention that they try to manage with. Just want to put that.
Thank you, that's very welcome. And I would say as well that has largely been my experience. There's a care home just outside my ward on the border of Acton Central and South Acton that has a large number of patients in it, and it seems to me that as things have progressed, things have been managed much more effectively as we've learned a bit more about what is the best way to deal with some of these situations. And I'm looking, and yes, Kerry has provided some more information, and he says the care homes management was significantly via the multidisciplinary care home cell in terms of managing infections. Additional investment was made available to Ealing Community Partners to increase infection and therefore reduce admission rates. So I think in between all those contributions, Alan, we've got some clarity on what happened and what changes were able to be made to deal with some of those problems as we went along and apply learning quickly. Kerry's also apologising for his poor connection. Well, it's happened to me already once this evening and may well do so again, so don't worry about that. Kerry, we're grateful for your contributions in whatever form we can take them. I did promise count him, so Councillor Steed, are you ready?
Yeah, Dan, hi. Yeah, I was just wondering, looking ahead somewhat, what the backlog is on various items such as elective surgery and non-elective surgery, and in a more general sense as well.
So Simon, would you like to off on that?
So I haven't got the absolute figures in front of me, but there are significant backlogs in place. How we're managing that is that in terms of what we class as priority 2, those that need to be seen within 14 days or operated on with 14 days, and those include the cancer and the most urgent and the longest waiters. We are prioritising those, and we've got the capacity in place to deal with those across our sites. And we're also using the independent sector to provide additional capacity, although at least we have been up until the end of April. And for some of the larger cancer cases, we've got some till the end of May at the London clinic. So the most urgent we're able to deal with. We are focusing on prioritising those most important ones. We are, with the additional capacity in place, though, now targeting the longest waiters that aren't quite so critical. But there is no doubt that the number of 52-week waiters has increased within the trust. So I think it was around about 100 pre-COVID. It's now up towards the 1,000 mark in terms of 52-week waiters. We have got plans in place to reduce that, and the target is clearly to eradicate those in priority order in clinical priority order. Those have been assessed by our consultants in terms of doing that, and we are also looking at working across the ICS in terms of prioritising the reduction in backlog. And as I alluded to earlier, if we can get back to 75% in June, 85% in September, then that will enable us to get on top of those backlogs. But for us, we've got a rolling average of about 400 patients that every fortnight are dropping into those P2 categories. And so where we've got 400 elective procedures available, they're always targeting those P2 to highest priority waiters who are needing the most urgent of operations. So that's our focus at the moment, and will continue to be before we can really move into the P3 and the P4 priority list.
Okay, thank you, Simon. Did any other colleagues want to come in on that point or add anything? If not, I'm just going to check that answered your question, Councillor Steed, and that you didn't have anything else you wanted to ask.
Danny, hi, thanks. Yeah, yes, I think it'd be useful to have a bit more information, maybe if Simon can follow up on that.
Yeah. We'll get you a more detailed response in terms of the longest waits in terms of specialties and what we're doing about it. But I'll need to prepare that in terms of a written response back to this committee.
That would be really welcome. Thank you.
Yeah, fair enough. Absolutely. Thanks, Dan.
That's all. Excellent. Okay, thank you, Councillor Steed. Now, I don't see any other colleagues indicating at this stage, but I do know that Eve Turner from Ealing's Sabre NHS wants to ask a few questions, and that she'd notified us that she wanted to do that in advance. So I'm going to give Eve a chance to ask her questions, and then Simon and colleagues can answer, and I'll come round for one more potential round before we move on. Eve.
Thank you, Chair. Thanks for taking my questions. I do want to make just a very, very quick comment, really, in relation to something that was said right at the beginning, which is about the community. And that is, perhaps, I don't need to remind people here that the community in Ealing is very, very much in support of Ealing Hospital, and has always appreciated the existence, and of course was engaged, as was our campaign, for a number of years to defend keeping open the A&E and all the beds. And aren't we really pleased? Definitely. And I'm sure our colleagues in other parts of the trust are, that it's still there to play the role. And I don't know you, Joanna. I hope I meet you at some point in the future, perhaps at a meeting, to chat to you a little bit as well. I'm pleased to see that there is a director of operations at Ealing, so that's good. And obviously very pleased to hear about the money that's being spent on Ealing Hospital after many years in which services were going in the opposite direction out of the hospital. So it's very good to have them back. So my question, which I've now just lost, sorry about this, is about the, is going back to this question of the reinstatement of trauma and orthopaedic and overnight surgery. And I did listen to what Simon said, but also really I did ask a similar question to the board, and there were a couple of things that Simon said that I just wanted some clarity on, and that was one of the things that's suggested is about looking at about the availability of resources as part of the review in terms of reinstating those services. And I wondered if Simon could explain a bit more what you mean by resources, because clearly there are still theatres at Ealing Hospital, and there are still surgeons willing and able to pick up that work as and when there is a return to trauma and orthopaedic work at the hospital, and similar for the overnight. So I wondered if you could say a little bit about what that is and whether there were adjustments that needed to be put in place in order for those services to be reinstated.
So Eve, we have prepared a written response that you'll get to the three questions. So I'll read an extract from that response in the first bit to the trauma, if you don't mind.
No.
And then I'm happy to follow up with any questions. So at present, the LAS trauma divert remains in place. This diversion has not resulted in any adverse incidents being reported by the sector, other trusts, or the LAS. Semi-urgent trauma care in theatres on a green pathway is provided to patients with hand and feet injuries following COVID-19 testing and self-isolation. Reinstating trauma will require the provision of an emergency theatre session manned out of hours by an anaesthetist, a theatre team with a minimum of 7 staff and an orthopaedic surgeon. Major trauma requires theatres on a red unscreened pathway, and for this to be kept separate from our planned green pathway. Given the build of our theatre block, it's not currently possible to do this for major trauma. The provision and use of staffing estate will be included in a review which will consider the best options to reinstate trauma service. This review is now being established. But it comes back to the previous question in terms of the backlog as well. So yes, we could have staff stood up for this pathway, but they wouldn't then be able to support the backlog in terms of some of our elective procedures that we've got. So there is an opportunity cost for us in terms of doing this. And at the moment, our judgment is that that whilst we're committed to doing the review, looking at how we can bring this back into place at Ealing, we don't feel we're in a position to do this at the moment, given the scale of the other challenges we got, because there's opportunity cost around the anaesthetists and the theatre teams at this moment. But that will feed into the review that will take place.
Can it just to say, I won't say well, but when you talk about no adverse reactions, I know of at least 2 situations where people didn't actually die, but it certainly sounds like there was a potential of deterioration in their condition through not being able to be operated, both of which were potentially trauma. But that's another issue. I will obviously come back to that, and I may feed that into future discussions. But when you talk about adverse reactions, it's not just death, obviously. It's
no, absolutely, agreed.
But I would just point out that Ealing is the only A&E in Northwest London that doesn't have that trauma service, and it's one of the most deprived. And so for us, it remains a major issue for us to get that reinstated for the community here. And I appreciate the issues to do with red and green spaces and how that interacts, and that is an issue, but it ought to be possible to still contribute to the backlog and still have a trauma and orthopaedic service operating. But anyway, we can obviously feed that in, and I hope there will be some proper public consultation. There certainly should be, because
absolutely,
when that takes place. So my second question, I'm trying to think, is quite a different one. It was really about the day haematology, because you did kindly write to us to tell us at the time that you were going to transfer the service to I think it's Central Middlesex, and that was partly due to staffing problems. And I just wondered what option, if any, are being considered, and if there's any timescale for returning that service to Ealing.
So again, that's been delayed because at the time I was saying that we weren't clear on the extent of COVID wave 2 and the impact of that. We have got the outpatient clinics up and running, and the support to the wards in terms of haematology patients in place. So that is in place. But the daycare facilities, that review is now planned for the end of quarter 1. So we'll be doing that in June. As I said, I think at the start, we do need to consider identification of a more suitable footprint to where it was previously located as part of that review. And we are also working more as it's one of the priorities in the ICS. It's a network approach for ICS for haematology services. And so we're working with Imperial around clinical pathways, and also extending hopefully getting support in terms of a joint, a new clinical director post that may or may not be a joint clinical director post with them, that might help in terms of creating some capacity and leadership for that function. But that'll be end of quarter 1.
Right, my last question is quite a big one. So I'm not really expecting much of an answer, but as you said, I just really want to flag it up because it remains the burning issue, I think, as revealed by COVID, which was, as I'm sure you're aware, Ealing has had one of the highest rates for COVID infection, if not the highest in London. And certainly, rates of COVID infection have certainly been shown to have a huge link to areas of deprivation and poverty and so on. And obviously areas like Southall particularly contributed to the high level in Ealing. And so I really am quite interested to hear what action, if any, the Trust is taking to address health inequalities within this borough, no doubt also across the Trust, in relation to planning services for the borough. I don't expect a very detailed response, but I just really want to know, you know, I'd love to see something in writing, but like to hear what sorts of things you might be considering.
So we will send you a written response on that I think Neha has also added to. So clearly we're working with the ICP in terms of that the impact from an inequalities perspective. I think within the hospital though, you know, clearly the sort of things that we've already talked around, the infection control process, the testing, the identification of the patients, and trying to protect them when they come into the hospital in terms of pathways. We've supported GPs with things like telehealth and advice and guidance, etc., in terms of managing their patients within the community. And also support around respiratory monitoring for those discharged with COVID, and also those COVIDs with post-COVID specialist care needs. We're sort of working in terms of making sure that they get access to the most appropriate care. And obviously, we were an early adopter of the vaccination and provided teams to certainly the Wembley Centre for vaccination during the period to support the broader community. But that was in Brent, obviously, rather than at Ealing per se. But those are the sort of initiatives that we've got in place within the Trust.
Okay. I think I do mean something broader than just COVID, but clearly in terms of future services at Ealing. But I think that's
okay.
I hope that's understood. Perhaps I wasn't specific enough, but that's really what I'm.
Well, maybe I interpreted it inappropriately then. But yes, I'm happy to talk about that at some point.
Great. Okay.
We're planning on doing.
Thank you very much, and thank you, Chair, for letting me ask those questions.
Neha, sorry, I was on mute. I've got Neha wanted to come in. So Neha.
Thank you. So just to add to that, as an integrated care system, we also know that we need to make sure that we are tackling inequalities and actively reducing inequalities as far as we can. So as a partnership board, as an ICP partnership board, which I'll go on to talk about in a little while, one of our key objectives and priorities is to reduce inequalities, and that's across the whole of the North West London system. Actually, the ICS and North West London CCGs are looking at the same. As a CCG, we've always worked really closely with public health to develop the joint strategic needs assessment as well, and use that as a basis for understanding where differences lie in terms of equalities and the population makeup and the disease or the where the issues are. And it's always it's a live document, but it's obviously needs refreshing because of COVID. And we, as commissioners, when we're commissioning services, rely really heavily on that, and we'll be working with our local authority colleagues to refresh that shortly. But it is something that is very, very high up on the agenda of the ICP board. But there's also a lot of learning, I think, from the vaccine in terms of the vaccine hesitancy and what we've done together as a partnership in trying to tackle that. And that will provide insight into how we go forward and tackle inequalities, I hope, as well. So that's just what I wanted to add.
Thank you, Neha. I've got Kerry. Let's try again, Kerry, see whether we've got a better connection this time. He's disappeared on me right now, so it's not promising. We may write down again. I wanted to add something at this point, and I hope I'm not. He's gone back on mute, so maybe he is going to write it down. I want to add something on this point about inequality and health inequalities. It's obviously something we've discussed at this panel over a long period of time, both with regards to provision of services and what the services are like at Ealing and other hospitals, but also it's a concern for the council and the administration in terms of what investments the council and local authority and public health can make to various different areas, because on any number of not just health inequalities but inequality in general, there are divergent outcomes right across the borough. So I do think there's scope for further analysis of this, both at this panel, at the JOSC, that will continue to scrutinise and move to scrutinising the North West London responses in general, and the new structures that are being set up that Neha alluded to in her own answer. And there's probably also potential for health-based analysis to feed into what the council's overview and scrutiny committee does in future years on this issue. So I do think it's relevant and probably deserves more time than we can give it. Maybe something that we could schedule for the work programme going forward. But on the broader points, Eve, we've had some we've had sight of written answers to your questions. Or I have certainly prior to the meeting. They will be published and sent to you, and we can always follow up with further questioning outside of the meeting and arrange discussions if that would be appropriate. I've got a contribution from Kerry Stevens, which I need to read out because I don't want him to be silenced. Health inequalities is a key aspect of focus which the council and the ICP partners are engaging with the ICS to ensure this is a key aspect of the North West London work plan. So I think that alludes to some of what I was trying to cover just now. But I think it's certainly worthy of further scrutiny, and we'd like to do that. I don't see any further, and thank you, Eve, sorry, for your contributions this evening and the contributions of your group throughout the year to this panel. They're very welcome. I don't see any other colleagues indicating to ask questions. So I did want to finish by thanking Simon, Joe, Neha, for providing their contributions tonight, particularly at a time when still there's a lot of other issues and a lot of other focus that needs to demand your read. Councillor Rosa, I may have missed you. Councillor Rosa, before I sum up, did you want to come in?
Yes, please. Just wanted to say thank you very much to the hospital, actually, because I've been I've been contacted by families who've had people who've died there, and they said that they were handled with a lot of care and a lot of sensitivity, and it was done in one case. Their daughter was in Australia, and they'd made special arrangements so that they could actually have her on FaceTime during that process. So
think we might have lost you just for a minute.
Huge thanks from the residents, really, because those of us who have gone through bereavements been handled very.
Ollie, I'll ask you.
I think we lost Councillor, but I think we got the broad gist of what Councillor Ross was trying to say, which was to appreciate the care and compassionate attention of staff at the hospital and how far they went to ensure that unfortunately, people's last days were comfortable and they were able to communicate with family and loved ones. And that sort of ties in nicely with what I was about to say, which is the panel is in no doubt of how proud and how loved Ealing Hospital is by, and that's shown in the number of questions and consideration that is given to Ealing Hospital matters here. But also we're in no doubt of the hard work, dedication, and quality of care and determination to get things right of the staff at Ealing Hospital, the clinical staff, and the representatives here this evening embody that. So we do want to send our thanks, sincere thanks, to everybody who's gone way beyond the call of duty in this very difficult time to support residents and to support patients. Really traumatic phase of the pandemic, and we hope that the contributions of residents in terms of how they rallied round to help are an indication of the strength of Ealing resident feelings about the importance of Ealing Hospital. So thank you so much for your contribution throughout the pandemic and this evening. I'm sure we'll return to substantive issues around Ealing Hospital in future, but I just wanted to put that on the record on behalf of the panel, how much we appreciate the hard work of the staff, and we would like to make sure that that's communicated to everybody. And I think Joe is writing that in the chat right now. So thank you very much, and we'll let you get on with everything else you do. Thank you for your time.
Many thanks for those kind words. We've got a team briefing tomorrow. We'll make sure your thanks are fed back as part of that process. So thank you very much.
Brilliant, thank you. We really appreciate that, and good luck for your future commitments. Right, so I'm going to move on to slightly later than Bill, the Ealing primary care update, and this is going to be brought to us by a combination of Nhs, Chris and Vijay. I think we've all already heard from it in some form already this evening. I'm not sure who's going to start. Is it going to be Nhs? Yes, it's going to be Nhs. Lovely. Okay, so I'll hand over to you.
Thank you. I was asked to bring a primary care update, but this update is a bit wider than that because primary care is being affected by the integrated care working, and I just thought it would be better to provide an overall update on the services that have been provided over the last year in terms of tackling the pandemic locally and the impact on primary care, but also our community services and what we're doing now as a commissioning organisation as well. So the paper is quite detailed, so I will take a few key points in particular from it. And starting with primary care, and over the last year, as everybody knows, and I've been to the Scrutiny before and explained how everybody was dealing with the vaccination programme and COVID response. But just to pull all of this together, primary care has been working under significant pressure, just like the rest of health and social care and other services across the system for over a year dealing with the pandemic. It's a very challenging year compared to what we thought it would be like at the beginning of 2020. Practices had to change their systems and processes almost overnight and gone through transformations that would have taken many years, literally in a couple of weeks, moving to total digital triage and different processes that have had to happen as a result of that. We have, over the last year, worked really closely with our practices, making sure that they are all and they understand the implications of what's happening right from the very outset of when COVID started to have an impact, with education sessions for the GPs to understand what we knew about the COVID at that time, working and arranging meetings almost weekly, in most of the time in the evenings, with all of our GP practices and over 100 people attending, 150 people attending from primary care, just to stay updated. They worked tirelessly to move to new ways of working and try and provide as much access as they safely could within their premises, but also remotely. Mobilized brand new software that they had never used before and had to support their patients to start using, like e-consult systems and a system called AcuRx, which allowed them to do video consultations. We worked really closely with all of our clinical directors 7 days a week, trying to set up a brand new escalation clinic for COVID, so that we had a a segregated place in the community where patients that had COVID and needed to be seen on face-to-face could come to a venue which was based at Mattock Lane in the middle of Ealing, and that was run by our GP practices as well, hosted by the CCG and West London NHS Trust, supported in terms of making sure that the staff had contracts in place to manage those patients. That meant setting up protocols and then adapting over the year as we learnt more about the disease. From that site, they set up symptomatic testing as well for health and care staff as soon as it was available, and provided care virtually to patients that had COVID that just needed that reassurance because they were dealing with COVID symptoms day in, day out. That's supported primary care to be able to put on these new different ways. It's important to remember that a lot of the workforce working in primary care, just like in a lot of our other providers, are local residents and have been affected by COVID just like we all have, and just like patients were suffering from COVID. Some of them were isolating, just like Simon was saying from the hospital trust. It was the same issue. So primary care was also dealing with that. We worked really closely to integrate with acute pathways, setting up a brand new virtual nephrology clinic, working with Imperial partners, but also creating an advice and guidance system over the year where GPs could contact through this this IT system, ask questions of consultants about managing a patient in the community, therefore trying to keep patients out of the hospital setting where it wasn't appropriate for them to go to, and keep them and manage them in the community. So they really stepped up to the mark to support the rest of the system. They also stepped in to support, for example, when 111 were drowning in calls for COVID, they took the additional calls at the hub itself, the COVID hub at Mattock Lane, but also in general practice, where they had slots available that 111 could directly book patients into or divert patients to manage in primary care. Some really, really innovative stuff that happened throughout the year, working across the whole community. But at the same time, we were doing everything we can to make sure that those primary care staff were safe as well. And where patients needed to be brought in, they were able to bring them in COVID secure environments, but ensuring they had PPE as well, so protective equipment as well, and undertaking risk assessments for all of the staff at an individual level around what their risk was to COVID as well, and how we could make sure, how the practice could make sure that they were continuing to work safely. But at the same time, they delivered one of the most successful flu programs in the history of Ealing, really, with the outcomes with over 75,000 vaccinations for flu delivered over the winter season, which was remarkable given everything that they were also dealing with. So just to move on to primary care networks throughout the year, as you all know, and I'm sure I've brought papers to the committee before around primary care networks, which was set up in July 2019. We have 8 in Ealing, serving with a population size ranging from 38,000 to about nearly 80,000 patients, and each of those primary care networks has a clinical director with funded time to support them to work with those practices in that local PCN. And they've worked really hard over the last few months, in particular, in delivering the vaccination program. And as PCNs, they've worked with their federation as well to combine to jointly deliver the 2 vaccination hubs, which I'll talk about the COVID vaccination hubs in the moment, and give you a bit of an update from the last meeting. But over the last year, although we've been dealing with COVID, one of the things we have been doing is trying to support them to think about the future and how they, as PCNs, want to develop. And they conducted a bit of a maturity matrix when they first started. Quite rightly, they were it was a self reporting maturity matrix where they rated themselves as foundation. But over the last year, working on the COVID pandemic and the response to that, and working with all of the partners, they have developed really strong relationships as PCNs and groups of practices, which is fantastic. Just going to move on slightly, pull out some key things. So one of the key areas that has worked over the last year has also been the support around the care homes. So PCNs, although they are supporting the vaccination program, they weren't actually delivering much of the vaccination in the care homes themselves. That was done by our roving teams, but also our community partners. But our community partner, and Chris is here, can talk a bit more about this. We put in an enhanced service for care homes over the year. So where there was a proactive call into each of the care homes on a very regular basis, on a weekly basis, almost from a clinician, to just make sure that there were no issues. And if there were issues, how they could then try and help resolve them for individual patients as well. So that's, again, helping with the COVID response. The vaccination program itself, we've vaccinated over 145,000 patients in Ealing, people in Ealing now, with over 50,000 having received their second dose as well, which is fantastic. And over 100,000 of those vaccinations have been delivered at the 2 primary care vaccination sites at Ealing Town Hall and Dominion Centre. But with primary care starting to ramp up and move back to some sort of business as usual and catch up with the backlog that they have, that has been created as a result of people, not coming forward, or the confidence levels of just following up with issues and lumps and bumps and things like that, that may just need that follow up and support in primary care. Primary care is really now feeling the heat, and the activity levels have really shot up and increased quite significantly. So as well as delivering the vaccination program, primary care is also dealing with that surge in activity to be able to deal with that backlog. So they will be stepping down their vaccination part, their part of the vaccination program, and we're ensuring that there is enough capacity in the local system to ensure that patients, the remaining patients, can get their first doses and second doses as well. But they continue at the moment, particularly providing the second doses. So as those vaccination centres step down, primary care will be able to get back to trying to deal with the day job and catch up with that backlog. And to support them, we have had the Ealing standard in place for some time now, which is a set of 23 to 24 service lines that we've commissioned through at all of our practices. And that contract continues this year, and we're now working across Northwest London to try and deliver a similar contract across Northwest London colleagues, and take the learning from various boroughs about what has worked well about commissioning these types of services and implementing that into the next year. So our new specifications, updated specifications, have gone live with diabetes and mental health as of 1st of April in primary care. So primary care is now starting to do all of the Ealing standard specifications that we were asking of them, also as well as all of the national contract requirements, and delivering the vaccination program. So as you can imagine, it's pretty heavy at the moment. Just moving on, as a CCG, back in January 2019, the NHS Long-Term Plan was published, which set out that NHS and partners would establish an integrated care system across Ealing, integrated care systems across England by April 21. And we have that in place, and it's as our partners were talking about, and Simon and Joe were explaining earlier, the partnership working across the integrated, across all of the partners across North West London has really helped deliver much more streamlined and safe care over the last year in response to COVID. And we're building on that. But that doesn't mean, as part of the long-term plan, with the integrated care system being set up, we also moved to take a vote of our member practices to move to a single North West London CCG as well. So Ealing CCG doesn't actually exist anymore. It came to an end on the 31st of March. And as of 1st of April, we became part of North West London CCGs. The local borough team remains, and we will continue to work really closely with our local authority and all of our provider partners, dealing with local Ealing issues, but working really closely with all of our system partners at North West London level. And as I was saying, it's really come into its own through COVID in particular. So as of 1st of April, as I said, the 8 CCGs formally combined into the North West London collaboration of CCGs. Earlier this year, there was also a white paper published, earlier this year or late last year, I can't remember now, all the time is blurring into one. But the government recently published the white paper on the future of clinical commissioning groups and integrated care systems. And as was noted within that, CCGs would cease to exist if approved, if this goes through royal assent, and following the debate in Parliament, CCGs would cease to exist in March 22. And from April 22, ICSs would become statutory organisations, which would replace the current governance that we have in place. As part of that, so as well as working as a North West London integrated care system with all of our partners at the table, we would also have a local integrated care partnership. So, and we've already started setting that up. As an integrated care partnership, we have a number of partners at the table with acute providers, community, mental health, local authority, CCGs commissioners, primary care as providers, and we are just working with our voluntary sector, some of our voluntary sector colleagues, to try and get good representation from voluntary sector as well as health as well, to set up an integrated care partnership board. That board had been meeting pre-COVID. The frequency of those meetings had reduced due to COVID, but we've now started to meet again and really reinvigorated the agenda and the plans that we want to develop as a partnership board going forward. And in the paper, I've set out the current priority areas that the partnership board have set out. The board is co-chaired by Dr. Vijay Taylor and Paul Nadzarak from the local authority, but it has all of those partners at that table, and we're just setting out the governance of how we will manage that going forward. That board will report into the Health and Wellbeing Board as well, so there will be an opportunity to see what's coming out of that. The key priority areas that have been identified so far at a very local level are children and young people, including CAMS, urgent and emergency care, and putting in responses in place and making sure we're working as a partnership board across the system to deliver these. The operational delivery of integrated care teams organised around primary care networks. So we're working with our primary care networks and our community services and mental health teams to wrap services around populations in primary care networks to deliver improved outcomes and really focus in on the inequalities that may exist or the needs of the local population within that local ecosystem. proactive care and managing long-term conditions, comorbidities in care homes, elective and the recovery of all services, as you would expect to see from health ourselves. And although mental health would be a part of all of these programs, actually possibly having a separate, slightly distinct conversation to make sure that we don't lose that agenda and focus on mental health, autism and learning disabilities. But that has to also be supported by a number of enabler work streams, which is around engagement, resident engagement, including all of our partnership boards and PPG groups that we have as well with our GP practices. Estates, digital transformation, workforce and training, because as we know, we will continue to need that workforce and continue to grow that workforce. And these would all work across all of the partners, not just for primary care or one part of the system alone. It would be across all of the partners. And the next steps for each of the leads for these work streams is to think through what the ambition is for the year and take that back to the next partnership board. So we'll be taking that through to the partnership board and then through to the health and wellbeing board going forward. But I'm happy to take any questions. I'm not sure Kerry, Chris or Vijay might want to add anything to that.
Yeah, sure. I want to come to each of them before we go to questions. Dr. Taylor was waving at me, so you'd like to go first?
Thanks for that. I just wanted to, first of all, for those who don't know who I am, so I'm Vijay, I'm a GP in Acton, and I'm the interim GP borough lead for Ealing. Dr. Mohini Palmer is now the North West London chair, so I just wanted to make sure, just want to highlight that. But thanks, Neha has given a very comprehensive overview of in terms of what has happened over the last 12 months in primary care, general practice, and generally speaking in the community. I don't want to repeat what Neha said, but there's a couple of things I just wanted to bring out. I think it's important to recognise that we did establish a local gold command. When the first wave of the pandemic emerged, and that was a really effective partnership between local authority, the public health, CCG, the community services and primary care, and it enabled us to come together to make some strategic decision making, and in effect a level of command and control, and we were meeting 3 times a week, when at the height of the pandemic. And it was a really effective partnership, which we had continued throughout the COVID pandemic, and we are in the process of now stepping that down until potentially another wave of COVID emerges again. The other point I just wanted to make was in terms of the COVID hub that we established in Ealing, and we. General practice came on board very, very quickly within a 2-week mobilisation programme to develop the COVID hub in Ealing, in Mattock Lane, and I think this was really important, and particularly in view of what we've learned about COVID, the disease itself, over the last 12 months. We in terms of the assessment and the monitoring and surveillance of COVID positive patients, what we've learned is that some patients with COVID develop silent hypoxia, and if we're able to identify silent hypoxia early rather than later, and particularly if their oxygen saturations are below 93%, if they get early intervention quicker and sooner, they can have a better outcome. So I think that has been a real enabler, and we've continued the COVID hub, even during last summer when the levels of COVID positive patients were diminished. We still kept the COVID hub up and running, and again through wave 2, and now, while we're down in the low levels of COVID at the moment, the COVID hub still remains open, and we will then need to review and understand what we do going forward in terms of the COVID hub. So I just wanted to highlight that. And in terms of general practice itself, business as usual did continue when COVID started, and Neha highlighted that general practice had to suddenly change their systems in terms of how they look after their patients, particularly using a remote consultation, video, telephone, e-consult, and that was important to ensure that patients are kept safe, so they are shielded and sheltered at home, but also to ensure that staff that work in primary care were also protected from COVID as well. So it was key that that approach had to happen. And now as the COVID activities dropped, general practice is getting more back to normal, in terms of level of face-to-face consultations that are occurring in general practice. There will be some consequences regarding COVID, and we know that, during the first wave of COVID, the level of 2-week referrals dropped by 80%. So patients, were reluctant to present with their potentially red flag symptoms, and clearly the level of 2-week referrals are now picking up again. But I guess in terms of consequences of COVID, we are just touching the tip of the iceberg. There'll be lots of manifestations of COVID, including patients who in our population Ealing who have now developed long COVID, having had COVID, particularly in wave 1 in March last year, and we need to work as a system to enable to support those patients with long COVID in the community, as well as the services of secondary care to support them as well. And then finally, I just wanted to just talk about the COVID vaccination program and the mobilisation of primary care workforce, and that was really key in terms of the success of both Ealing Town Hall and DC, and so primary care workforce came forward to try to deliver the vaccination program, and that did mean staff working unsociable hours, particularly in the weekends, lots of volunteering to be able to deliver that on top of doing a day job as well. So they've done an excellent job to deliver over 140,000 vaccines, and in fact both our sites have delivered, in terms of level of vaccinations, the top 5 in Northwest London. So so that's been a real success story of collaboration, and I think it's important to also understand, and Chris will come in here in terms of what we did in Ealing in terms of nursing homes and residential homes, and it has been very, very difficult. We know that in terms of our residents in residential and nursing homes, in terms of the care that they needed, but also their extended family as well, in terms of limitation of access that they had for their loved ones, and it has been very, very difficult for everyone. And lots of lessons have been learned, particularly around the disease itself, but also in terms of how we manage COVID in the community, and how we continue to ensure that we provide good care for all our residents.
Thank you, Vijay. Really useful insights there, and certainly in terms of the work that the primary care staff have done in delivering the vaccinations. I know colleagues will say the same. I've been inundated with emails and phone calls from residents saying how the setup was, how safe they felt, how appreciative they are of the work that everyone's put in. So if you're able to feed that back at all, we'd be immensely grateful that can be shared. And it's also interesting to hear you speaking about the importance of collaboration and the opportunities that envisages both at the moment and going forward, hopefully. Chris, did you want to add something?
I'm happy to add something, but don't want to prolong the item unnecessarily, other than to say that the community services and the mental health services locally have been working very closely throughout this period with staff from the CCG primary care colleagues, and as you heard earlier, colleagues from the local authority and the acute trusts. I think there were a mention of the working care homes, which we covered earlier in response to Alan Cook's question. But I think there is ongoing work, and Neha mentioned the enhanced health in care homes model. That's a national model, and Ealing, to some extent, was several years ahead of the curve in terms of the commissioning of a dedicated nursing home GP practice. And I have to say, I think you're all very familiar with the work of Dr. Down and her colleagues. But they have really been doing a huge amount of work, including the deployment of the vaccinations, first and second doses to nursing homes, whilst colleagues from primary care have also been supporting the residents of residential homes. And we have further work planned over the coming months to provide a more sustainable enhanced care offer to all of the homes across Ealing. We've been working really closely with the local authority, and Kerry has mentioned before in the chat his care home cell and the efforts we've been making to try and upskill and provide advice and support to care homes through the IPC investment that the local authority asked us to help them spend. So I think really just again to say we recognise it's been difficult. Our focus in the community and mental health services at the moment is now on recovery, and from an Ealing Community Partners perspective, it is stock taking some of the transformation aspirations that we had before the pandemic, to ensure that they are still relevant, to see if they need to be updated in line with the learning about how we have worked together, and also to be realistic about our opportunity to continue implementing those, and to recover from the last few months.
Okay, thank you, Chris. Kerry, you've got your hand up, I think.
This is my last attempt to speak. Can you hear me?
No, I don't think this is going to work.
No, the comments.
Okay. Okay, Kerry's written a long comment, which I will read out. The close partnership working across the sector via the ICP is key to providing the best outcomes for the communities we serve, but also to ensure influence at the ICS regarding issues which are local to Ealing are heard and respond to. The council is clear that its role is to ensure that the localism agenda is responded to within the North London discussions and commissioning plans. And I think that reflects some of what we've heard from other. I have missed out, unforgivably, Councillor Rosa, who did want to also say that residents have been full of praise for the delivery of the vaccinations in Ealing, and record that, as I mentioned earlier, but I know colleagues want to come in on that. Mr. Cook has got his hand up. Mr. Cook.
Yes, thank you, Chair. With regards to the vaccination programme, at the last scrutiny panel meeting, we were told that 47% of staff at care homes were currently vaccinated, and in the BAME community, the figure was 48%. Could we possibly have an update of what the situation currently is, please?
Sure. So I don't have the BAME numbers to hand at the moment, but the care home workforce, because I know Kerry would want to say this, so I'm talking for him, but he's put the numbers in the chat. There you go. He's already put the numbers in the chat for you. So 78% of council social care staff have been vaccinated, first doses. Care home workforce has gone up to 71%. Which is fantastic, up from that 44% before. And the home care workforce, the domiciliary care workers, has gone up to 55%. And then for the second doses, the care home residents are at 81.7%, workforce, care home workforce is at 43% already, and the home care workforce at 21%. But they will be getting their second doses in line with everybody else as well. And we're continuing as staff are going out to care homes or anywhere, we are continuing with that message about please come and take your vaccine, and trying to answer any questions that come up from staff as well. I've done a lot of work around vaccine hesitancy and webinars and things like that, which this is what I'm sure Kerry would have wanted to say if he could.
Yeah, I've got Dr. Taylor wants to come in on the points.
Yeah, just you're right, Alan, in terms of the BAME community, the figures, particularly the low uptake of the Afro-Caribbean population, and we us locally with the borough team and local authority have been working quite hard to try and come up with some solution as to how we can increase the uptake, particularly in the Afro-Caribbean. And I think some of the figures around between 40 and 50% of the uptake, particularly in that group. So, and we are trying to work together to try and understand why the uptake is low in this particular cohort of the population, and what we can do to try and encourage them, because they are potentially one of our highest risk profile in terms of COVID complications.
Okay, thank you, Dr. Taylor. Neha, is that what we call a legacy hand, or did you want to come in now?
Sorry, I just wanted to also make a plug. So we've been doing a lot of work in the community, and this Friday we are going to have a vaccine bus in
yes.
Park Avenue Gurdwara car park to try and really get into some of the communities. And it's the first, and we're hoping we'll be able to do more to really try and reach out into certain communities that may be hesitant to come into one of the vaccination sites.
So just on that point, before I come to you, Councillor Alan, Councillor Steed has put in the chat, directed to me, but I think more to everybody else, that these figures still seem low, and I think that's recognised by the contributions of Dr. Taylor and Neha on this point. I know that at a previous point in the pandemic, we had some opportunity to link up with the mosque, one of the mosques in Acton, which is close to where I represent, and obviously that Dr. Taylor knows very well. And I would say that from my conversations, we're still going very strongly in terms of trying to communicate with different groups and everybody really about vaccine hesitancy. I'm having a lot of conversations with constituents who are currently younger than the vaccine has rolled out to, and some of them have expressed some concern about whether the vaccine is really necessary and all of that. So I certainly think that work is ongoing. I don't know, Councillor Steve, did you want to voice your question rather than me making a mess of it like this?
Danny, your eloquence is far greater than mine. No, I mean, I just find that figure, particularly on the home care workforce of 55%, quite shockingly low, I have to say. And I understand the issues involved and the efforts to increase it. But I mean, if I'm a resident and I am being visited by a home care workforce, I mean, I guess I would kind of assume in a way that they were vaccinated, but nearly half of them are not vaccinated. I'm not quite sure what you do about that, because clearly that workforce are needed and they're required by people. So you're unlikely to turn them away, but at the same time, I would be very, very concerned about it. I can't say more than that, Danny.
Sure, no, I think we all appreciate and share the concern. So, Kerry, is being very helpful and contributing via the chat. So he says, on the first point, vaccine uptake within the in-care sector workforce is above average compared to the rest in itself is probably alarming, given the still relatively low numbers. And he says that home care staff are still required to use full PPE as per national guidance to prevent transmission. But I know that discussions are still going on, and work is still focused around working with those members of staff. I know for my part, I'm talking to the trade union representatives who some have links in with some of these staff members, and Councillor Raza makes a good point as well with regard to the footage from India helping with uptake. Lots of Asian residents now getting in touch about how they can be vaccinated. I know we've had a push on various Asian language television stations and radio stations and other forms of communication with regards to that. So I think it's certainly one to keep an eye on, and I know everyone's trying their very best, but we also have a role as councillors in terms of being vocal about encouraging people to present for the back, to apply for their slot, present for the vaccine, not be worried about their symptoms, and then to encourage other people to take the vaccine as well. So I think it's important that we do our part as local leaders and are as engaging as possible. And I know you all know that, but I wanted to try and emphasise that point. Alan, sorry, I'm not sure if you were waving at me while I was speaking then, you wanted to come back, or if that's all, I'm sorry. Did you want to come back, Alan? I think you might be on mute.
Sorry, are you referring to me?
I was trying. You made a gesture as though you might want to come back. And
No, sorry, I was looking at something across the screen and I turned my head. Sorry.
Okay, no, that's absolutely fine. Right, Councillor Burke, you were next. Sorry, you've had to wait.
So it's kind of more of a sort of medium-term question, really. I mean, I think some of the challenges about the care staff and care homes are as a result of long-standing issues in terms of a fragmented sector and, largely a sort of a not very well paid, etc. workforce, so that we don't have that much to do with. So a couple of things really. One is how much are we having to do with the employers when it's a different, because there's my understanding is we have a significant number of different employers in Ealing, and and how the efforts they're making to make sure that their staff are vaccinated. And secondly is really in terms, again, long term, because some of this funding will go away, as somebody alluded to earlier. And I think, again, it exposed some of the issues about the challenges of primary care working with the care sector, for example, in terms of who was responsible for training and infection control, etc., etc., etc. So if not for today, I think it would be useful if you're allowed, Dan, to put on the work programme for next year, something around how we get much better, hopefully in a post-COVID world, about how we integrate and work with primary care, working with the care sector. I just think that's something that COVID exposed, right, which had been a long-standing problem. And I think we've learned a lot through this, as you've all alluded to, and there's been some really good practice. But my worry is the funding goes, COVID goes, and basically a lot of people in care homes were dying from other kinds of infections, again because of some of the systemic problems with this. But sorry, that was a little bit of a kind of an over-egged comment, but really it's just about what are we doing with the employers and what pressure can we put on them to make sure that they're actually really engaging with their own workforces.
In relation to the point about that programme, it's well made, and we already have a suggestion from Mr. Willis and his group about a scheme of work to do with social care. I think it's very worth while adding your suggestion, Linda, as well, and we'll come on to discuss that hopefully. Now, Kerry has rejoined with a new device and has his hand up, so I'm hoping this is going to work. Kerry.
Can you hear me now, Chair?
Much better, Kerry. Yeah.
Hurrah, hallelujah. Just to say that the continued close working with the employers within the care sectors is key, and that they have been central to ensuring that we can get engagement with the staff group who, for various reasons, do have some hesitancy in terms of the vaccine. There's been a strong focus to make sure that the engagement's been maintained with this sector of the economy, Councillor Burke. In terms of the funding question, I think that's an absolutely pertinent point to be raising. There's been quite a lot of funding provided by national government to support the care sector over the last 12 to 14 months. The expectation is some of this funding will be coming to an end shortly. The last tranche was received very recently, and we're keeping a very close eye on what the impact will be on the care sector of that money ending.
Okay, but I take the point that Councillor Burke has made about further scrutiny being necessary. Chris did put in the chat, and he's quite right to do so, that there is a current consultation from the government about the possibility of addition of people being employed in care homes. I know that's generated quite a lot of comments so far. That's certainly something that's being considered. Kerry, did you want to come in on that? You've got your hand up again. I don't know if that's a mistake or if you're eager to contribute on this as well.
Yes, so the consultation that's going on, as Chris raises, is going to be a very key issue for the sector. It brings issues and benefits with it that will be taken due consideration of. I'll try and lower my hand now, Chair.
It's all right, don't worry. No. We're just glad to have you in this fashion. Absolutely. Right. Now, Councillor Murtaugh, I don't know if you were wanting to come in when you turned your camera on, or if that also was a mistake.
Thanks, Danny. No, it was just an error. So thank you.
Okay, no problem. No problem. I like to be as inclusive as possible. I don't see anyone else wanting to indicate at this point. I'm just going to pause because people may wish to say something before I sum up. And I'll sum up in this. Roy, sorry, you've come onto my screen, and I think you're trying to attract my attention. Mr. Willis. Yes, go for it.
Yes. That was one of the questions that we had listed tonight, was about the vaccine rollout and how the priority groups are managing in terms of getting access to the second vaccine. I think the answers have been given on that question, but I did want to just follow up something quickly in the sense of, are there any supply issues in terms of supplies of the vaccine? Is that holding us back in any ways? Because I did notice that Ealing Town Hall had been closed for a week or so, a couple of weeks ago. So I just wondered if there was any supply issues.
Right, I'm not sure who's best placed to question from our esteemed panel. Oh, I've got everyone's putting their hand up. So, Dr. Taylor, would you like to go first?
Yeah, just on respects to the supply issue. So, in terms of second vaccinations, the second vaccinations have all been ring fenced. So, and it mirrors the delivery of the first vaccination at the two sites at DC and also at Ealing Town Hall. So when you mentioned that it was closed for a particular weekend, that's because the delivery of the second vaccination didn't land on that weekend slot. So that's the reason why it would have been closed. But we have got the assurance that second vaccination supplies all been protected and ring fenced. So we don't have any issues on that. We are still waiting for the green light in terms of when Moderna will be coming to Northwest London. We haven't got confirmation when that will be the case, and we are aware that more supplies of Pfizer are coming to Northwest London, and there is going to be a pause in the supply of AZ during the month of sort of overlapping between May and June, but we are confident that our priority 1 to 9 will all have had their second vaccination, and as you know, we're now working on we're down to 42 plus in terms of the age group for first vaccination. And we are also working logistically in terms of the assurance process that we need for our mass vaccination sites to have Pfizer, because of the transportation and storage of Pfizer, it is more of a fragile vaccine compared to AZ. Our mass vac site, CP House, and also all our pharmacies have been using AZ up until now, but we are working through to have Pfizer at our CP House in the coming weeks as well.
Okay, Neha, I'm not sure if you were wanting to come in or if you were pointing to somebody else. So Neha,
I did just want to come in to add to that. So there have been ebbs and flows of vaccine supply over the last few months, but that's based on the national. I think everyone's heard of when the supplies have gone down, but in Northwest London, actually, we've had more than enough supplies to continue our vaccination program. I think it is important to note at this meeting that, and it's nothing to worry about, but our 2 PCN vaccination sites will be closing down at Ealing Town Hall and Dominion Centre in the next few weeks, because primary care that is purely run by primary care, and primary care needs to get back to business as usual. So we are ensuring there is enough capacity at CP House and the pharmacy sites that we've established, and continue to work with them to make sure there is enough capacity to continue the vaccination program now that the most vulnerable cohorts have been vaccinated.
Okay, thank you, Neha. Kerry, did you want to come in? I wasn't sure if you were indicating to me as well. No, I think that's you shaking your head, Kerry. Thank you. Sorry. But Eve Turner from Save Ealing, Save our NHS. I'll get it right one year, Eve.
It seems to be a crisis. Chair, I'm really conscious of the time, so I just want to flag up my question, but I'm not particularly looking for an answer today, which is it's a long-standing issue for us about how groups like us can have a relationship with the ICP board, and it's not about whether you have one rep on a resident involvement board or something like that. It's about having some sort of real relationship. But in view of time, if I can just flag that up for Naya and VJ and others, and maybe hopefully we can have a bit more discussion about that another time when there's more time. That's it. Thanks. And you know, you're doing been fantastic job on vaccinations, and so on. I share everybody's views about isn't it great when the NHS does it as opposed to when private companies do it? Anyway, I'll say no more. Thank you.
You got it in there, Eve. I knew you were going to. That's excellent. Well done. I would say, obviously, we've spoken in various forums about the importance for dialogue, not just with campaign groups, but for residents as well, who have probably just got used to the last set of NHS reorganisations and acronyms and things to do with their health service. So, you know, I would reflect upon that and say that it'd be useful to, when you're ready to tell us about a dialogue and how that will work in practice, and how people can feed in their ideas or concerns or praise, as we've heard this evening, then that would be really useful. Right, I'd like to, and in view of the time, I would like to thank everybody. I know each of our contributors has many pressing things on their mind at the moment. I'd like to thank you all for your attendance and your continued dedication and diligence to for everything that you're doing in our community. Well, once again, everybody really appreciates it. We're so grateful for everything that you've been doing and the success that you've had so far. We really appreciate it and want to express that message fulsomely to you this evening. So thank you for your time and your insights. Thank you very much. Now, and with that, I'm going to see if we can move successfully on to the social care item with Kerry, hopefully ready to give us the promised verbal update that looked in danger at one point this evening. But Kerry, off you go.
Thank you, Chair. So I've provided the update with regard to the vaccine rollout in terms of the care sector and the improving position in terms of first and second vaccines to the sector, which is absolutely key for ensuring we've got continued safe provision of services to the community. Last time I spoke to the group, I think we had 6 care homes closed due to COVID outbreaks within the care home sector. Currently, we have no care homes closed due to COVID outbreaks, and we've been in this position for the last 4 weeks. So there's a significant shift in terms of the impact of COVID on the residential and the care home sector. As a result, we're reviewing the position in terms of the ongoing scrutiny and oversight of the sector, and we'll continue to provide assurance in terms of partnership working, but we'll be agreeing to or looking to agree to step down the regularity of the care home sale, which has been working at various levels of engagement across the sector from 3 times a week. We're currently meeting once a week, but we're likely to step that down to once a month in the very near future. Services provided by the council continue to be provided on a remote basis in the majority of areas. We are providing direct services through council resources in terms of our reablement services, our group homes and registered care providers. Social work staff are continuing to work remotely. However, we are still making visits into the community with regards to safeguarding concerns and emergency and escalating situations with customers with complex needs. Chair, I was going to do a bit of a short update on the learning disability in the daycare sector. Is that okay to do that now? That was relating to a question from Roy.
Please, go for it.
So Roy's asked a question relating to the support that's been offered to the daycare sector and the position of how we're working to develop the services in line with the national roadmap. Just to update the committee, that the council's been working very closely with the daycare providers in the borough and with our own directly provided services in terms of daycare since wave 1 in March. We've continued to provide funding where services have been closed, and we're working very closely with the daycare sector to ensure that they're reopening, which started on the 12th of April. Has been done in a COVID secure way. We've been working with transport providers to ensure that where services are opening, that the transport has been provided in a safe and secure manner. And we expect to do that in a continued manner as services begin to reopen in the coming weeks and months as we move to full reopening in line with the government roadmap. There's routine PCR testing in place within the daycare services. Access to work-based and home lateral flow testing via the government portal has been made available, and staff have been offered vaccination in line with what we've been discussing earlier. We've been carrying out risk assessments and providing safe certification for services as they've opened. And as I mentioned earlier, there's been daycare transport risk assessment. Roy asked about how we're working with customers and their families to ensure that people feel safe and secure coming into day services, and that's something that we've been working closely with customers and their families with regard to, and retain strong communications with families throughout the period when the services have been closed, and supporting individuals whilst they're remaining at home and not staying attending day services. The in-house day services at the Michael Flanders Centre in Cowgate have remained closed throughout the period of the pandemic, and we're looking at plans for reopening those services. Michael Flanders Centre is the centre for people with dementia-type illnesses, but that site is also being used as part of the testing programme for the council, and I'm very clear that we need to ensure that as sites open, that they do so within a COVID secure arrangement. Hopefully that answers the majority of Roy's questions, but happy to take further questions on that if anyone should wish to ask them.
Sure, thank you, Carrie. What I propose we'll do is we'll go first of all straight to Roy so that he can follow up on any of those and add any additional thoughts that he has. So I think you're ready, Roy, to come in.
Yes, indeed. Thank you. Yeah, thank you for that answer, and that deals with most of the question. I suppose the only other aspect is because of the prolonged lockdowns and the closure of day centres, there has been quite a change in staffing in terms of people leaving, people being made redundant, staff not being available. So I'm just worried about how we can successfully reopen centres if there isn't the staff available, and it will have to be some recruitment. And is that viable if we're not sure about the attendances at the day centres?
Carrie, you want to come in?
Yeah, thank you for the question, Roy. Certainly, people may have made the decision to work elsewhere going forward. We know that the council's got a very strong plan and response to the concerns about the levels of unemployment in the borough, and we'll be working with day centres if there are recruitment issues to put them in contact with people who are looking for work who would be suitable and beneficial to working within that sector. I mean, the funding that we've provided to the day centres throughout the crisis, Roy, has been significant, and we've been very conscious of the importance of providing stability within this sector, because it's so important to the people who use those services and to their families.
And just to add, I think I know Councillor Rye's not here, but and I wouldn't presume to speak for her, but I know that the administration, from my discussions to the sector and the need to deal with this and continue to invest, certainly in light of the government's real lack of long-term plan for social care and some of these residents. So, you know, we're certainly aware of the issues and would like to explore them further in the next year, which is something we'll come on to when we discuss the work programme, which I know was one of your asks to us this evening, Roy, in at least one of your questions about some more scrutiny of some of these issues. And I'd certainly like to recommend that to colleagues for the next year of the work programme, that we have at least one or two sessions delving into some of these issues more deeply. And I know that, not wishing to speak for Kerry, but I know that he would welcome additional scrutiny and recommendations from this panel if they were possible. So not to preempt that question, but we'd certainly like to do that. I'm conscious that I came straight to you, Roy, and haven't asked other members if they have any questions. I haven't seen any in the chat box, but that doesn't mean that people don't have questions. So I'll just wait for a minute to see if anybody wants to indicate. But of course, I know Kerry would be very open to taking questions via email or in writing following this session, because I know we've covered a lot of ground already. But obviously, this is a priority for the council, and remains a priority for many of our residents indeed. As well, many of us will get correspondence about social care and what's been happening in the lockdown. I know that's been coming up in our inboxes. So with nobody else indicating. So Roy, unless you've got another question that you'd like to ask or another comment that you'd like to make, I'm going to move on. But tell me if you'd like to say something. and I'll take you. Yes, you would like to go for it, Roy.
Yeah, well, the third question was about the charging issue, and I was going to say that our group has always argued for the abolition of non-residential charges in social care due to the unfair, punitive, and intrusive nature of the means testing involved. And I was going to ask if we could have a feasibility study to look at the financial and practical implications of abolishing these charges in line with the non-charging policies of Hammersmith and Fulham. And it'd be interesting to get a report that looks at the benefits and deficits of the charging system, how bureaucratic it is, if mistakes occur and causing problems for the whole of the across the board. And so I was going to ask if there could be a report, a feasibility study to look at whether it's actually worthwhile having a charging system, and whether it could be changed or abolished.
Well, so I don't. Carrie wants to come in. There's something I want to say first of all with regards to the purview of this panel. I would imagine that recommendations regarding that level of decision making would flow to the cabinet rather than this panel. But my comments previously were around encouraging of us taking a wider review of the social care sector and some of the issues that have arisen. So we could certainly feed some of that in, but I'm conscious of the fact that budgetary decisions are the purview of the cabinet, and I haven't yet had the discussion with Councillor Ryan and her colleagues about what the council's budgetary considerations are for the forthcoming municipal year. But Kerry, you were indicating before I started speaking, and I didn't take you until now. So please come in.
Thank you, Chair. You've made the points that I was wishing to contribute. I think this would be something that would need to be considered by the executive within the council, but there's no reason why we couldn't have that discussion with the executives if they were wishing to take that forward. Just to say that in terms of the income from charging across adult social care, it's approximately 20% of spend. So it is a significant budgetary impact.
So I'm not trying to fob you off here, Roy. I'd certainly like to have the issues and have the discussion in the most appropriate forum, and it'll be for the next chair of this panel to decide what comes to this panel. But in terms of the decision-making process, a review of that nature would have to be originated by the executive.
Yes, I take the point. I thought that might be the answer, but I think it's clear that Hammersmith and Fulham have been able to make a local decision. So I just want this issue to be discussed more widely. It may be, of course, that national policy changes will change this issue anyway. If there's a total reform of social care reorganization and social care changes in the way social care is funded. But I'm sure I don't want to take up any more of your time on this, so I'll leave it at that. Thank you.
No, don't worry. I mean, your point is well made, and I'm quite happy on an individual basis to speak to my colleagues in Hammersmith and Fulham to find out the reasons behind why they've taken that decision and what flows from it. But I can't, the final decision will be taken in the budgetary process by the executive. But I would like to see some element of this encapsulated in our work programme. So one way or another, I hope within the next year, we'll have a discussion around some of these issues, and you'll be able to make your points on behalf of your group to the right people, so that it is considered within the next 12 months.
Thank you, Chair. Thank you.
Okay.
Yep.
Yeah. Questions from colleagues. So I'd like to thank Kerry for persisting with this technology so vigilantly this evening that we could hear from him in the best manner, and also for giving us that update. I would suggest that we can, as I've said to Roy through this discussion, that it should be something that we continue to focus on over the coming year, and that feeds us in quite nicely to the next item, which is the discussion of the forthcoming work programme. And I don't want to I'm certainly aware of the time, and also the fact that I'm asking current members of the panel to recommend what the next panel should look at. But I'll kick off with a few suggestions, and we don't really need to prolong it for too long, I don't think, this evening. But I do think some of the stuff we talked about tonight, the COVID pandemic, there's still some work we can do around lessons that we've learned and partners have learned from the COVID pandemic, particularly as well with regards to the kind of health inequalities that contributors were speaking about this evening. I think there is recognition from the panel and some of our contributors that we do need to keep an eye, as Mr. Willis has suggested this evening, around adult social care and some of the changing issues in adult social care, particularly with the government's review and potential for a solution, as he was speaking about. And I do think we need to keep an eye on the progress of some of these new developments with regards to the ICS, and also with regards to Ealing Hospital. As we've heard this evening, the future of Ealing Hospital and our local services has been something this panel has sought to scrutinise over a long period of time. As we get back to regular business, if I can phrase it that way, then we will need to look at the financial arrangements for Ealing Hospital and healthcare in general, and what the aims and objectives are of North West London going forward. Look, that was a whistle-stop tour of what I thought might be appropriate, but I am at your discretion to add and other matters that you consider appropriate. And Alan is already ready, poised to give us his.
Thank you, Chair. I think one of the big issues from the COVID situation over the last year is the effect it's had on safeguarding issues and the number of safeguarding issues that have increased. I think that's something that, as a panel, it ought to be looked at, and to see in Ealing if there has been a rise in the number of issues or not. And if there's not been this rise, then obviously either it's not being reported, or in fact, let's give them the credit that Ealing is actually functioning much better than other places. So I think that's we'll have to be looked at, because I know from the 111 point of view, I'm quite heavily involved in that on a monthly basis. I sit on a particular committee, and we hear that these issues do take place. And so I think actually it's a reflection on what's happening in Ealing could be quite helpful.
Yeah, I would certainly keen to add that into the COVID section for sure, but equally it could generate some standalone time as well, particularly if we want to praise local services. And I would say we certainly want our partners to bring forward items, as they have done in the past, either about changes to services or projects that they want to give wider attention. I know it's not the best time to be asking colleagues on this particular evening about plans, but I do want to everybody to know that we're accessible to taking input. Has anyone else got anything they want to flag up? You can, of course, write to myself and Anna-Marie subsequently, and I think we've got a good basis for some topics that would carry on into the next year. I'm not seeing anybody wanting to make contributions, so I think I'll take your general silence as acquiescence. Councillor Raza wants to keep an eye on the bodies that replace the CCG, and mental health will be key coming out of COVID. Yeah, absolutely, Councillor Raza. Mental health has been a key focus of the communities in general, and access to mental health services is always something we hear when we're allowed to go on the doorsteps and when we're allowed to conduct our surgeries and obviously in our correspondence. So I think that's very important. I would say, and it would be remiss of me not to mention, that some of the North West London bodies are going to be scrutinised still by the North West London JOS, which in a couple of weeks will firm up what its plans will be for the forthcoming year. And this panel will send representatives, as it always has, to that as well. So, and Chris is saying that he's very happy to ask mental health colleagues to provide an update, including regarding the implementation of recent investments locally. Look, we'd be really appreciative of that, Chris, and I should say we're very to colleagues for giving us their time. I'm going to close that item there, and I would just like to close by saying thank you to all of you, because we're coming to the end of our scheme of work for this year. It's been a very challenging period for everybody, whether you're intimately connected with the health service or not, in terms of how you go about daily life. I hope that we've managed to continue with health scrutiny, even though it's been challenging at times to get all the reports in and to try and cover the enormity of everything that's going on. And left with, as I've said a couple of times this evening, is an immense sense of pride with the work of NHS staff, partners, volunteers, and how much everybody values the health service in this part of the world. That's never really been in doubt for me, but it's shone massively over the last year to 18 months. It makes me very proud to be in this borough and to see all the hard work and data that is displayed on a daily basis. I would like to personally thank our contributors, particularly our NHS staff and representatives and our community partners. Since I've been the chair, we've had robust discussions at times, but I've always been very grateful that you've been willing to come to the table, present issues, and nothing's ever been too difficult for discussion here, and I think flourished as a result of that. I would like to thank as well our co-optees, in this instance Anna Whitty, Alan Cook and Matthew Van Mile Jones. You add immense value to this panel with your expertise and experiences, and I hope that we can keep you all involved in some way as we go forward. But I certainly wouldn't be able to delve into some of these issues personally as much as I do without your guidance and support. And I'd like to thank everybody on the panel who's put up with me and contributed so widely to our success in scrutinising the health service. And I would like to thank our officers as well. Kerry, in particular, for wanting to put issues before us. Anna Marie is brilliant. I certainly wouldn't be anywhere near as effective at doing this job if she didn't tell me where I was going wrong and remind me of all the important things that need to be covered, and also her colleagues in the Democratic Services Unit. Really appreciate your time, and Councillor Steed has got his hand up, so I'll hand over to Councillor Steed.
Thank you, Chair. Thank you, Danny. It befalls me and it's an honour that I can, on behalf of the panel, the partners, the co-optees, everyone who you've already mentioned, to thank you, Danny, for being the chair of the panel. It's always a pleasure, a genuine pleasure, dealing with you. I'd like to note your expertise in this role. I'd like to praise your successful attempts to be as inclusive as you are, and also just to acknowledge your genuine empathy with the issues that we have been discussing in the panel. You make it an enjoyable panel to be on, which is no mean achievement. I'd also like to pick up at your point and thank Anna Marie, who, as you rightly say, really controls the panel. I wish you and your family all the very best, and thank you again for your hard work and diligence over the past year. Thank you. Take care, Dan.
I think this meeting's going to close shortly, because otherwise I'll stop crying. That's very nice of you. Thank you very much. And thank you, everybody, for your hard work, kind wishes, and let's stay safe, keep getting everybody vaccinated, and beat the pandemic. And I hope to see you all